thoughts on distal humerus fractures and my take on this. So I'm just going to start with showing you an example of a 35-year-old man who's fell from a 10-foot high and had an open grade 1 fracture. He was only overweight, but no other medical problems. So these are the type of injuries that I'm talking about. So what I'm planning to do is take you through the anatomy, fracture patterns, approach, fixation, failures, and what I've learned from these, and some take-home messages. So the medial and lateral columns of the distal humeral at angle at about 45 degrees, and they're joined together in the trochlea and the capitellum, which is the thigh arch of structure that you'd often see. And on the lateral side, the capitellum is the most distal fragment, and the epicondyle on the lateral fragment. So what we're talking about is evaluation. Of course, you need to evaluate the patient first on the ATLS principles, making sure there's no other injuries. Generally, radiographs are performed. Sometimes it may be difficult to get proper views and hence traction views, even intraoperatively or peroperatively. Before you start the procedure, gives you an idea. CT scan has revolutionized what you can assess, and certainly the 3D CT images gives you a fantastic idea of the fracture patterns and make you pre-op planning accordingly. Beware of the comminuted capitellum and trochlea. And also, I think when you're starting off, it's a good idea to speak to your radiology team so that they get the orientation of the images properly. So the outcomes of these or the management depends on 3 factors. First is the fracture personality. So this is an example of a elderly patient, low demand with a very low fracture, highly comminuted, and these can be dealt with humeral head replacement, which Rajesh is going to talk about in more details. Patient personality, choosing the right patient for the right treatment is always great. If you've got an elderly smoker, unreliable, then you are in for trouble. So this is another case who's a young man, overweight, obese, not very reliable. The fixation I thought looked reasonable, but at 3 months, the plate snapped. And again, there was learning for me here, which I will share in later on slides. Surgeon personality is very important, knowing your limitations, what armamentarium you've got, and certainly in places which are less fortunate than UK, where you may have limited availability, one needs to plan rather than do whatever is available. So this is a 50-year-old man with this intra-articular fracture. These are not my images. A friend from India shared this with me. And this is what the primary surgeon did. I would suggest that you're probably better off leaving this in a plaster, but not do this halfway house fixation. Luckily, the patient came in early for a second surgery, and the outcome was reasonable following this. We all talk about classifications, and with distal humerus, there's a number of classifications that are available. And in principle, a good classification should be able to describe the injury, help manage a plan and the prognosis, and also be useful for research, have good inter and intra-observer reliability. But as with most classifications in orthopedics, even distal humerus failed to find one. The two that I found useful was one described by Jupiter and his team, which was a T fracture pattern, a high and a low. These are generally simpler to manage. Then you've got these, what they describe as a C or a Y fracture, and further comminution, or the lambda type fractures, which you need to be aware of and plan your plate placements accordingly. David Stanley and all his team described, which I found probably one of the better ones, which gives you an idea as to what approach may be useful, as well as outcomes. So type 1 is the extra-articular fractures, and going on the severity and the angle with or without the combination. Type 2 is predominantly intra-articular, but still has got a metaphyseal fragment. And the type 3 is mainly the intra-articular fractures, which is your capitellar fractures or the trochlear fractures. And these are managed completely differently. Surgical treatment is probably indicated in a lot of these patients, especially the ones which are displaced. Positioning, I generally tend to do them in a lateral position, although it can be done in prone, but your anesthetist will not be very happy with the prone position. I use a tourniquet, and approach is generally a posterior in an adult. And imaging is quite vital, because last thing you want is struggling when you are in the middle of a complex procedure. I make sure that I can get the image intensifier properly before starting. The approach is vital, as the reduction influences the outcome in articular fractures. Must be able to achieve a good reduction, and hopefully this will influence the outcome. And although for the distal humerus fracture, there's a number of exposures, choose the one that fits the fracture pattern. So distal humerus, you've got choice of different approaches based on age, the fracture pattern, procedure, associated injuries, whether there is an open wound. If we look at a bit more detail to the distal humerus, so you've got your medial approach, your posterior approach, your anterior approach, and the lateral approach. For an adult distal humerus fracture is the posterior approach, which is what is most commonly used. And in the posterior approach, there are two broad groups: the triceps preserving, which could be based with an osteotomy, or a paratricipital approach, or a triceps reflecting, which, based on whether you go from the medial side or the lateral side, is the Mori approach or the trap approach. I'm not going to go into details of these, as these are easily available for people to see. When you first expose, whichever approach you use is to tackle the ulnar nerve, I always isolate and tag it. I put a vascular loop around it. I do not put any artery clip or any other instrument, as it's likely to get tangled and cause a traction type of injuries. There is no clear evidence that routine transposition is required. In fact, the evidence may be the other way around, but you need to make sure that you identify and protect the ulnar nerve throughout the procedure. And if the fracture is going proximal, you may even encounter the radial nerve. The treatment principles are anatomic reduction, provide a good stable internal fixation, presto the articular axial alignment, and provide a stable internal fixation so that an early range of motion of the elbow can be started. Fixation-wise, I guess partly implant determined by the fracture pattern. For an extra-articular fracture, you may need to use one or two contoured plates. These days, lock plates make life easy. For the intra-articular fractures, I would certainly suggest that you need dual plates, and then whether we put 90-90 or a parallel plating is the question. The parallel plates was popularized by O'Driscoll from Mayo, and he suggested that the parallel plate provides us an external scaffold once you've done a direct reduction. And these are the principles which needs that all screws pass through the plate, all fragments engaged by the screws, and each screw should engage the fragment on the opposite side. They should be as long as possible so that there is an interdigitation within the distal fragment, and this provides a stable fixation. The 90-90 plates are easier than putting the parallel plates, but once you are used to doing the parallel plates, they become fairly easy as well. Indirect reduction for extraarticular comminution, stabilized by spanning plates, and micromotion healing by callus formation. If you look at literature, biomechanically parallel plating is superior to 90-90 configuration, certainly in the rotational element, but clinically there is no suggestion that one is superior to the other. Just take you through some of the examples. So what I call the good, the bad, the ugly of the distal humerus fractures. So these are what I would call the good fractures, which is an extraarticular fracture, big chunk. For these, I use a paratricipital approach, and then held by two parallel plates, provides early motion and early healing. The bad is where there is intraarticular comminution. So this is a 35-year-old female who came to me a few years ago now, fell on her hen do, and her wedding was scheduled 8 weeks later on, and wanted to have this fixed so that she could have her arm out of a plaster and getting her movement. So for these, I use the osteotomy, use a 6.5 millimeter large fragment cancer screw for my tension band. I drill and tap. And the key here is to use a long screw till you start to catch a bite into the ulnar medullary canal, usually over 100 millimeters. Then use Marcus chevron osteotomy. And the final bits I used, completed using an osteotome or a McDonald type approach. So that, and it comes out at the non-articular surface. This is what the picture appears once you open the fracture and you put the jigsaw together, close using a tension band wire, and then early motion, and she was happy. At about 3 months, the fracture had almost healed, and these are her clinical pictures. She did come to have the tension band wire removed later on. The ugly fractures are the ones which cause the surgeon a headache. So this is that same example that I first showed you. So this was an open grade 1 fracture with comminution in the metaphysis as well as into the articular surface. This was about 10 years ago that I did this. At that time, the availability of anatomical plates was limited. And you can see here the tension band, what I was talking about, the length of the screw, it needs to engage in the ulnar medullary canal. Overall, I thought the alignment and the reduction was quite good. And this is at 5 months where it looks to be healing with some callus formation. But at 10 months, the plates snapped, both of them. And going back to the previous x-rays, now in hindsight, I could see that that callus formation was more of an instability rather than a healing callus. This was managed by revision fixation, where I excised the non-union, compressed the fracture, and then it went on to heal without much problem. 3 months later, he had a further fall and came back with an avulsed olecranon fracture. You can see this is not where the osteotomy was done. This is more proximal to that, which was fixed with a tension band wire. But unfortunately, he went on to develop some infection and even ulnar neuropathy. Eventually, it all settled down, but it took months for this to go away. Yet another patient who is a 50-year-old chap who had an open grade 2 fracture of this distal humerus. This was not fixed by me, but you can see an attempt at fixation, 2 plates, and this failed fairly rapidly within a few months of the fixation. You can see the plate snapped there, it's not in line. This was then revised to the more anatomical plates, and the healing seems to be going okay. But at about 6 months, he started to develop some wound infection, and so the plates was removed. and the 2 screws were left as the fracture was found to be not healed. Unfortunately, this carried on for months, and I referred it to a senior colleague. This is about 10 years ago, where patient ended up having an elbow replacement as he developed degenerative changes. But this was complicated with appearance of heterotrophic ossification. And these are his images 6 years down the line after the elbow replacement. So again, what looked like a simple fracture caused more problem. If you look at the literature review, this was published recently, Complications of Articular Distal Humerus Fractures, looking at nearly 2,500 elbow fractures. Vast majority of them were type C. Overall complication rate was nearly 53%, and the reoperation rate was 21%. And it showed perpendicular plating approach showed significantly lower overall complication rate compared to the parallel plating. If you look at more details, what it showed was 53.4% total complication and a variety of complications enumerated. Luckily, non-union is not that much of a major problem. We can see the hardware is still a significant amount of problem. If we delve in and the reoperation rate was nearly 21%. If we delve in further and look at this fracture subgroup, so in the type B, which is less combination, less intra-articular combination, there was seen in younger age group patients, increased incidence of OA, increased incidence of implant discomfort and stiffness, and overall reoperation rates were higher. In the type C, this was more in the older age group patients, more neuropathy, less hardware, and more hardware malfunction, probably suggesting the low demand with the less of the other problems. What about the approach? So when using an olecranon osteotomy, this was seen in more use in an older age group patient. Increased risk of OA suggested probably that the articular side involvement significantly increased non-union and malunion and implant removal. If we look at type of fixation, looking at parallel versus perpendicular, the overall complications is higher in the parallel plates, and this is true for neuropathy, implant prominence, as well as wound problems, but as well as reoperation rate. However, the main difference is that revision surgery for failure of fixation is significantly higher in perpendicular plates than compared to parallel plates. It's just from my failures, looking at what I found over the years, is if a patient has a metaphyseal comminution, especially on the lateral side, I've found these to have caused problems in the years. So in summary, open reduction is indicated for most displaced fractures. Elbow replacement is an option in patients with poor quality bone and low functional demands. Chevron osteotomy is the preferred type of olecranon osteotomy. Routine transposition of ulnar nerve has not been demonstrated to be beneficial. And I suggest choose the appropriate approach, safeguard your ulnar and radial nerve, respect the soft tissues, familiarize with the particular approach. And if there is a metaphyseal combination, I would always suggest to use parallel plates rather than perpendicular. Thank you very much.